Okay, I will try not to run into Johan Hari's time because, being squeezed between Charles Blow and Johan Hari and all the other speakers is pretty intimidating. And I have given talks in other places, but I have to say this one has really gotten me nervous. Something about being in my own backyard, not wanting to embarrass the agency. Although I am starting with a moment of gratitude, and I did want to thank, I could spend the whole time on that, which would be meaningful to me, but I did want to mention my longtime boss, and I was a kid who used to say, "You're not the boss of me," so you can imagine I still kind of live in that world, but he has been, Bob Bick has been my boss for many years, and he told me he needed to leave during this, so when he leaves, it's not because what I'm saying is so horrible. But, so there's many people to thank. I'm very grateful. I've been this month at Howard for 24 years, which was quite remarkable. And it's the job that I wanted, and I'm grateful for having been there. But I wanted to dedicate this talk, as my people say, I'm going to get verklempt, but I wanted to dedicate it to two people, Carolyn and Will, who died, who I knew in very different ways. And, the talk is overcoming adversity. I don't think it's for me to say that another individual overcomes adversity, but they faced adversity, and they've moved me, and I love them, and I miss them. So this is for them. People tell me I'm passionate, which I always think is code and a kind of sexism, but I guess I've decided to own it as I get older. So I'm talking about critical psychiatry, and for some of you, this is a diverse audience in a lot of ways, may not know what that means. So what I'm going to do is talk a little bit about why I've come to define myself as a critical psychiatrist, and talk about some of the historical and cultural events that have influenced my profession. And then, because this is about bold initiatives, I'm hoping to introduce a couple of ideas that I think that could be helpful to the field, and I'll define what all of this means. But I've been told that a good model for a talk is to say what you're going to say it, and then say what you've just said to people. I'm trying to adjust this. So I'm going to tell you where I'm heading, and it's this concept that I've sort of borrowed from other people, slow psychiatry. And it's analogous to the slow food movement, which is a pushback against industrial agriculture. And industrial agriculture is successful as what you think of an outcome is production. We're very good at producing things. But if you think as an outcome as how we live in the world, in concert with the earth, with the planet, in concert with other animals that we share this earth with, you might say industrial agriculture is a failure. And people have moved to slow food to say we need to pay attention to all these other different things, how we live with the earth, how we take care of the animals that we may be raising to eat, how we feed each other, how we think about food. And so this is I'm taking that analogy, that metaphor, to psychiatry. A lot of people think the problem with psychiatry is that there aren't enough psychiatrists. And it's true in Burlington, if you're looking for a psychiatrist, it's very hard to find. And so the idea, one solution, is to get a production model. See people for 15 minutes. The American Psychiatric Association has a model called collaborative care, where the psychiatrist doesn't even see the individual. They see rating scales that the person's completed and then opines on that. So again, as with industrial agriculture, if the outcome is how many people, this is like a bad joke, how many psychiatrists does it take to screw in a light bulb? Now, how many people are getting in to be seen, that model may be effective. But I think from other rubrics, which is what people want in life, how are we addressing the kind of distress people have, I think we may be failing. And I'm going to suggest that psychiatry's purview, the area of human experience that has come under the umbrella of what psychiatrist does, I think has gotten too broad, and I think it needs to be narrowed. At the same time, I think when we get involved with people, I do think it's complex. I do think we have something to offer, and I think we need to slow down. So I'm going to try to explain why I've come to those beliefs. So the first part of the talk is going to be about critical psychiatry, and I call this slide, "What is Water?" And that's taken from a very famous talk by the novelist David Foster Wallace. And he gave this talk to a class of graduating seniors in college. And he talked about a fish, an older fish who's swimming, and he passes two younger fish, and he says, "How's the water?" And they say, "What is water?" And in that talk, he was about, you think your life is going to this point, and your life is what you're swimming in right now, and pay attention to that, don't lose that. I'm using it also to say, really, what is water? That there's assumptions that we've made. I think there's assumptions that have been made in psychiatry that I think have broadened to our culture about how to think about human distress. What is the nature of human distress that I think needs to be challenged in a fundamental way? Now, there's a broad area of critique. I don't have the time to talk about all of it, but I'm going to highlight certain things, which is that I think there's a flawed diagnostic system. And again, I'm only going to skirt over that, but I'm going to assert that I believe the diagnostic system that we use is flawed. There's a big problem with conflict of interest. It's really what got me into thinking about psychiatry in a critical way. And I think another important thing is the minimization of the voice and participation of those with lived experience. And it's beyond, although it's important to have advisory councils and people kind of giving us feedback about the work they've had, but I'm talking on a deeper level, a participation of people with lived experience in even shaping the question, shaping the nature of the research, shaping the nature of the work that we're doing. Honestly, I think this beautiful talk we heard this morning was a manifestation of that. Hearing from Charles Blow about his experience and having that inform us has an enormous amount of value. And I can tell you there's some really brilliant people doing work. You're going to hear from one of my wonderful colleagues this afternoon, Leslie Nelson, who is an example of some of that. And this is part of what's influenced me a lot, and a part of the critique. So what am I critiquing? What is modern psychiatry? Again, it's a very long talk, but I'm going to define, for the purposes of today, what I'm talking about. So psychiatrists are medical doctors. My mom would want me to say that today. She wants this live stream, but my poor mother, 2 kids, we both went to medical school, and then we both became psychiatrists. So it's sort of like, so there's a lot for her to deal with. But anyway. But the nature of medicine is the nature of understanding pathology. So the training embeds in us this notion that's focused on an individual and identifying the pathology, the problem within the individual that we will call illness, or in psychiatry often use the term disorder. So that's just the nature of medical thinking. Now, what psychiatrists become today is prescribing psychoactive drugs to treat those conditions. There's a lot of focus, and not just in psychiatry, medicine, in the mental health field, on outcomes, rating scales, treatment algorithms, what I would say is a technological way to assess and define these problems. So these, I think, are sort of major currents in psychiatry. Now, I think that people have, people have and will seek out drugs to alter mental state and mood. They've done that for a very long time, long before the era of modern psychiatry. And I happen to think it's a really good idea to have a specialty within medicine that understands how these drugs are used. So I'm not anti-drug. I'm going to talk about shifting the way we think about these drugs. I'm not at all anti-drug. I think we need to own it and be very, very good at that. I think it's an important area of knowledge, but I think it can be done in a somewhat different way. So to contextualize this, I want to talk about what I think are some major cultural, historical events that have shaped the water in which we're living in. So first of all, there were many psychoactive compounds synthesized in the 50s and 60s, and that was really the dawning of modern psychopharmacology. Another thing that happened is in 1962, an amendment was passed to the U.S. Food and Drug Act in response to thalidomide. That's a drug that caused very severe birth abnormalities in the children born to women who took that during pregnancy. And at that time, the FDA required for the first time that a company needed to demonstrate that a drug was effective for a particular condition. Prior to that time, they needed to demonstrate safety. So that seemed like a good thing. And what I'm going to talk about here is good intentions and some unintended consequences, okay? Another thing that was happening around this time was an increase in recreational drug use in the 60s and 70s. And I think that led to a need for psychiatry to distinguish what it was doing from what the kids on the street were doing. And so there became a narrative that I think exists to this day of good drugs and bad drugs. You'll hear this in even our talk about the cannabis situation. And so there's like recreational marijuana and medical marijuana as if they're distinct things. And I think this is this discomfort and push-pull. I mean, I have colleagues that don't like that I call the substances I prescribe drugs. They want me to call them medicines. And I think that comes from a discomfort that we have about what we're doing. Another change in the world, last night I got panicked that I wasn't using neoliberalism the right way, but I'm glad that Charles Blow isn't here. But anyway, anyway, what I'm talking about is shift politically in our country and a lot of the Western world, that reducing the welfare state. And it leads to, and I think we heard this a little bit this morning, that there's a narrowing in what is acceptable, what is allowable, how can a person be a contributing member of society, and I think that pushes has an impact on the psychiatric discourse. Now, I think a very important change, there was the notion of the illness model, the notion of the broken brain. There's a book written by a very prominent psychiatrist in the late 80s called The Broken Brain that expanded this. And I think this was an important and, again, well-intentioned attempt to push back against some other not-so-good things. And these were things like moral shaming, that these conditions were considered weaknesses, something wrong with the person. And also there was a lot of narrative about families, and particularly moms, being the cause of these problems. I always thought it was particularly cruel to say to a mom who brings her child to you who's struggling to say, I know that this is something you did, early on, and there was an enormous and understandable pushback to it. But I'm going to come back to this and just raise the question of whether this well-intentioned shift accomplished what we hoped it would be. And then finally, and I'm not going to talk too much about it for time, I won't go into it, but there's been a struggle within American psychiatry between the psychoanalysts and the biological descriptive types. And the biological descriptive types basically, and I think there were a lot of factors to this, kind of took over beginning in 1980 with the publication of the modern diagnostic and statistical manual that we use to render diagnoses in psychiatry. So I'm going to introduce a concept called economies of influence so I've just gone through this list of things. What does this mean? How can I make sense of it? Well, a professor at Harvard Law School, Lawrence Lessig, has coined this term economies of influence. And what it means is that there can be multiple influences that result in institutions acting in ways that deviate from their stated mission. And the idea is that when we talk about corruption, that's a very heavy word, right? And when we talk about it, you might say, he says it's the distinction between thinking about bad apples versus bad barrels. So the bad apple would be there's a few people scheming to do bad things. And there are some bad people that have schemed to do bad things. But what he's talking about is how institutions act, and partly in reacting to these influences that may lead them, as I said, unintended consequences, in a direction that, as I wrote, deviated from their stated mission. Now this was applied to psychiatry in a book by Cosgrove and Whitaker, and they sort of went through this model and looked at these different influences, and their conclusions is that all these different forces, some of which I've just outlined, resulted in a tendency to conceptualize human distress as medical in nature, as chronic, and requiring drug treatments. So I want to give you an example to demonstrate that. So what happens when a drug company has to demonstrate that its drug is effective for a certain condition is that they do a study for a certain condition, and they get patent protection for the drug that they've done. Now that drug, that brings them a lot of money. Our drug companies, this may shock you, are capitalist companies that are driven by an obligation to their shareholders and making money. Now, when the patent is coming out, if they can do a study to show an indication for another problem, they extend their patent protection. And what we've seen happen is this broadening of indications for drugs. So I'm talking about two classes of drugs, the antipsychotic drugs, which is in my wheelhouse. What I do for a living, what I've done for many years, is to work with people who experience psychosis. I'm going to talk a little bit more about this. And then I'm going to talk about the psychostimulants, because in a way these are kind of opposite drugs. So it's sort of a demonstration about how this isn't confined to one class of drugs. So when the antipsychotic drugs were introduced, they were for the treatment of a condition that we call schizophrenia. But what's happened, particularly in the past 20 years, as there have been newer drugs, what we've seen is a broadening indication. So now they're being used for problems called bipolar disorder. And we've seen a tremendous expansion by what we mean by the diagnosis of bipolar disorder. I think we had a grand rounds on this, and there's now like 6 forms of bipolar disorder, each of which bring in under the umbrella more and more people. It's now, if you go home and watch, at least if you watch the shows that I watch, or at least the shows that my husband likes to watch, you'll see advertisements for antipsychotic drugs for the treatment of depression. This is a new area. Mood stabilization, again, a much broader area than just focusing on the treatment of schizophrenia. They will be used for insomnia and anxiety. And you may say, well, these are scientific discoveries, and I'm going to come back to say why I think there's influences beyond science that have led to this problem. But schizophrenia affects about 1% of the population, depression about 20%. So you can see where there may be a profit motive that would have contributed to this. And similarly, psychostimulants were initially marketed for the treatment of the drudgery of female life in the 50s. A lot of drugs were. I mean, it's very interesting to go back and look at all drug advertisements. And then they were used for children with cognitive challenges, subsequently called attention deficit hyperactivity disorder. And then what happened, and this really shifted a lot in the early 2000s, coincident with a lot of other blockbuster drugs going off patent, well, we started to expand the definition of ADHD. Now we were saying, instead of being a developmental disorder that typically resolves by the end of adolescence, this is something that is with you for life. And a lot of people, for the first time, are being diagnosed late in life. So again, you can see the market expansion there. A new disorder was created, binge eating disorder. That means you overeat. So again, in our country where overweight and obesity is pretty common, that's a very big market. Mild cognitive impairment after menopause, depression. I sometimes think it's amazing someone hasn't tied me down to give me those drugs, because I have so many indications. So, TMI, but anyway. The other thing I want to talk about is what I'm going to call the recovery chronicity paradox. So on the one hand, there's this narrative of great advances in neuroscience, drug development, psychiatric therapeutics. But coincident with that, and an advantage of being old is I've lived through that and seen the changes in how we conceptualize these things. Because on the other hand, we've shifted conceptualizing a lot of these problems as time limited to chronic. So it's this funny narrative. Hey, great, look at us. We have all these great treatments. And guess what? You're going to be on this for the rest of your life. And I think that also is part of these economies of influence. So I'm going to give you an example, because again, you can say this is science. We learned this. We studied this. It's a new finding. And I think there's more to it. So in schizophrenia, as I said, my area of expertise is in treatment of people with psychosis. Now, schizophrenia is a concept that was coined around the turn of the last century. And Emil Kraepelin was a German psychiatrist who began to take what was the advances in modern medicine at the time, kind of categorizing people's signs and symptoms, following them over time. And he said in those mental hospitals at the time, there was a group of people that had a illness that was chronic and deteriorating. He called it dementia praecox. It was later renamed schizophrenia, and it was instantiated in our modern DSMs. It's considered a chronic illness. Now, is that science? I mean, he never found the neuropathology he was looking for, and we've still not found it. In 1980, there was a study that I want to highlight because this is a Vermont story, and it was a study that counters this. So in the 50s, George Brooks literally brought chlorpromazine, the first antipsychotic, to Vermont State Hospital. And he gave it to a lot of people, and a bunch of people got better, but there was a group that didn't. And he went to them and said, help me understand how I can help you leave the hospital. And he created an innovative rehabilitation program, and he was a researcher, so he tracked this, he collected data, he followed them for about 10 years. And then in the late 80s, this young graduate student at the University of Vermont Department of Psychology was working on her thesis, and someone said, you know, Vermont being Vermont, I bet you can find those people. Let's see how they're doing. And she did, and what she found is that 70% of them were in recovery. And these were the people that were the chronic mental patients who did not respond to antipsychotic drugs. And what happened to Courtney Harding? It was discounted. I'm proud to say that Courtney Harding was invited to give grand rounds here at the University of Vermont just a couple of years ago for the first time ever. And that experience is not, it was what happened in her reception around the world. People, said this can't be true. So I think, what I'm suggesting is it was an economy of influence. That was an uncomfortable truth that fought against the narrative of chronicity. Now, the other thing that I talked about is that the understandable need to fight shame, shaming of individuals and shaming of families. This is an important thing, but did the broken brain model do that? So I just want to raise a question. So I'm just going to cite 3 studies that question that. In one study, they found that an increasing belief in the biomedical model increases a desire to maintain social distance from people diagnosed. A second study found that psychosocial explanations reduce stigma and increase empathic responses. And finally, a third study found that patients who are not stigmatized have better overall outcomes, self-efficacy, quality of life, and improved chances of recovery. Now, I'm highlighting self-efficacy because I think that's a really important concept. The sense of agency, the sense that you can do something, I think is important, and I'm going to come back to it a few times during this talk. So, that's the end of this kind of long intro of what is critical psychiatry and what I think are important issues that we need to think about, important questions that I've had, that I have brought to bear to my practice. So what do you do? This is about bold initiatives. So I'm going to introduce 2 ideas that I think could improve my profession. So the first one has to do with an alternative way of thinking about the drugs. So this is an idea that I was introduced to by a British psychiatrist, Joanna Moncrief. And what she has articulated is that there's these 2 different ways to think about drug action. And one is what we use now, what is commonly used now, which is the disease-centered approach. And that's a direct consequence of that FDA act that drugs are treating a certain disease target. But implicit in that, and what has been highly promoted, is that these drugs are correcting a problem, that they're a specific drug. I mean, if any of you were watching TV in the 90s, you might have seen a commercial where little serotonin bubbles were marching along the screen. Serotonin is a chemical in the brain that helps cells communicate with one of them. And the biggest selling drugs of that era were Prozac, and they're called selective serotonin reuptake inhibitors. And one of the drugs had a commercial where it was sort of implying that the drug treated the depression by having an effect on serotonin. Now, it does have an effect on serotonin, but there's really no data that the problem of depression has to do with too little serotonin, which was the common narrative. But that would be a disease-centered approach. We're fixing your serotonin. And so, you need this drug to fix your serotonin. And that model has been applied with all of the drugs that we have today. Now, in a drug-centered approach, we're thinking about these drugs as psychoactive substances, meaning they alter mood, cognition, brain functioning. But that problem, it creates an abnormal, or I'd say an altered brain state. And that altered brain state is superimposed on the condition that you're trying to treat, and the superimposed condition is what helps a person. Now, the example I like to give is that I'm a socially awkward person, and I don't do very good. I do good with long talk. In fact, I might run over, but I don't do well with short talk. I'm not that good in those situations. So when I'm in a situation like that, I feel awkward and uncomfortable. Now, if there happens to be some alcohol around, I've learned that a half a glass of alcohol will help me feel calm and comfortable, and I'll get through it, and I'll have a much better time. Now, you could say that I have cocktail party deficit disorder, and that this is the drug that's treating my condition, right? That would be a disease-centered way to think about me. But you could say I have a brain. My brain reacts to alcohol the way most brains do. In the short run, it's sort of mood elevator, a little bit disinhibiting, that, I dose it right. I don't really like alcohol that much, and so I'm not vulnerable to some of the downsides of it, and I'm using this psychoactive substances to help me have a better time at the event. So that's what I mean by this. Now, I want to apply this to my area of expertise, antipsychotic drugs and schizophrenia, because this isn't for me an abstract concept. I think this has really serious, important implications for how we use the drugs, how we think about them, how we talk about them with people, and how an individual who is ingesting the drug is thinking about that experience of taking the drug. So, what are the antipsychotic drugs? Like, they were synthesized in the 50s, they were used in surgery. Now, a French surgeon noticed that they caused, this is the psychoactive quality, a state of indifference, that they were different from other tranquilizers. They didn't make the person go to sleep, the person was awake, but seemed to have this state of indifference. And I'm highlighting that for a reason. And then if you look at an American textbook, fairly modern American textbook, normal volunteers, that's what it means, a drug-centered approach. What does it do to people who aren't having the condition you're trying to treat? And what they report is that in normal volunteers, it causes dysphoria, is unhappiness. Part of medical school is you just learn a different language so you impress your mother and other people. But anyway, so these like fancy words for things. Paralysis of volition. What does that mean? You don't want to do things. You lose your get up and go. And fatigue, tiredness. So that's the drug-centered approach. How do we use these drugs? What's the standard of care? Well, the standard of care today with psychosis is to initiate the drugs early. There's a hypothesis that they might prevent further worsening of what's considered this underlying brain condition, that you continue the drugs indefinitely to prevent a recurrence of the underlying condition, and that the poor outcomes, if you see poor outcomes, which unfortunately we do observe, people not returning to work, not having friends, that is because it's due to this condition that Emil Kraepelin told us 100 years ago was chronic and persistent. That's the standard of care. So what I want to do is talk about a couple recent studies, and what I'm pointing out, and this is why I think it has concrete impact to shift this view from disease-centered to drug-centered, because the outcomes of these studies seem paradoxical from a disease-centered point of view, but they would have been predicted from a drug-centered point of view. So the first study is from the Netherlands, and they studied 128 people who were experiencing a first episode of psychosis. They were treated with antipsychotic drugs. And then they decided after 6 months to separate them. And one group stopped the drug and would start them if they got symptoms again. The other group stayed on them. They did a 2-year study, reported their findings, and they found that the group that stayed on the drugs did better. They had fewer relapses. Now, this had been done before. It's why we recommend treatment indefinitely for people. The issue, though, is that people often get these conditions when they're fairly young, and people are on them for a lot more than 2 years. They're on them for decades often. So this group decided to go see what was going on with these people 7 years after the study had started, 5 years after this one had ended. And this is what they found. So at 7 years, the relapse rate between the two groups had evened off. What it looked like continuous drug treatment had done was just to postpone, but not absolutely prevent relapse by 7 years. But the more important finding that I have highlighted there is the group that was on intermittent drug had a much higher rate of recovery that was defined in a very robust way. And the difference, the two groups had sort of equal levels of what are called of psychotic symptoms like voices and unusual ideas. It was about 70% recovery rate in both groups, which is interesting when you think back to the Courtney Harding study. But the real difference was in the rate of having a job, having friends. And it was related to dose. They also analyzed their data according to those on very low doses versus other doses. And the people that could be maintained on lower doses had much better functional recovery. The other study that I want to talk about is from Open Dialogue in Tornio, Finland. And I'm going to come back and define this a little bit more, but for the purpose of this moment, one aspect of Open Dialogue is they don't believe that the drugs are essential all the time and indefinitely. So they treat people quite differently, and you can see here, so this is a 5-year outcomes of first episode psychosis compared to a cohort group in Stockholm. And you can see the different rate at which they use the drugs. But I want to draw your attention here to the rate of disability. It's much, much lower in the Open Dialogue group than in the Stockholm group. And so this is similar to what Wondering found. So how do I take that back and apply it to the disease versus drug-centered point of view? Well, I've talked about what the disease-centered point of view is, but in the drug-centered point of view, what you're saying is these are drugs that induce a state of indifference, kind of a dampening down of thoughts. Now that can be enormously helpful for people in the throes of a psychosis. If, psychosis can include hearing really awful, loud, intruding voices, having beliefs on things. Like I may look around here and see people with glasses, and that may have some very ominous, serious meaning to me that's very, very frightening. I think these drugs can be life-saving. I am not anti-drug. It's a different way of thinking about them. So I think that dampening down can be enormously helpful for people at certain times. But when the drugs are stopped, you may think this is a drug that has altered brain chemistry in some way, and we know that to be true. And we might want to think about what the implications of that are, particularly when the drug is withdrawn. Has it sort of created a state? I talked about alcohol. We know that when alcohol is withdrawn, people can get very sick. Well, any drug that's altering the body in some way when it's withdrawn, you might want to think more about what that means and not just assume everything you're seeing is due to this underlying condition. And then I think more importantly, you might think that it's possible that a drug that causes indifference may over time, may over years and decades, cause a state that leads a person to be less likely to be able to participate fully in his or her own recovery. So that's my second major point. I really did not want to run into Johan Hari. So I want to, what do you do with this information? Well, I talked about slow psychiatry. I think that this is a complicated conversation. I know I've put a lot into this talk, and I hope it's not confusing, but how do you sit with an individual, with a family, and talk about this complexity, not take in a position that's very diagnosis-based, that's much more kind of embodying the uncertainty that I think is, that fits with the state of knowledge in my field. And I have this idea of integrating this drug-centered approach with something called need-adapted treatment. So I talked about Open Dialogue. What is need-adapted treatment? Very quickly, this was developed in Finland, and it was during their era of deinstitutionalization. We were doing the same thing here. And at the time, they said, there's a lot of different ways to think about these problems. There's all these different models. Every model has its own treatment. Some models are helpful for some people, not for others. We don't really know how to apply this. And they had this idea to bring in the person at the center of concern and the network, the family often, and say that to them. And what they found was those conversations in and of themselves seemed to be healing. And they then set off on what's ongoing work is to understand the nature of those conversations. And that's what need-adapted treatment with Open Dialogue is. And it's a basic therapeutic attitude that acknowledges different paradigms, that values uncertainty, values humility, is flexible, democratic, less hierarchical. As the doctor in the room, I have a perspective. I'm not giving up my perspective, but I'm positioning it on a more equal level with other perspectives. And I think that's a valuable and important thing for psychiatrists to do. And this is just kind of going through sort of differences here. So the medical model, there's an evaluative process that leads to a diagnosis, and that then drives your treatment recommendations. Whereas I've talked about how this works in open dialogue. Our system right now is it's assessment-oriented referral. It can be extremely fragmented. People at their worst moment of crisis may be having to tell their story to multiple people. In open dialogue, you work with a team that sees you through the crisis. In standard treatment, the problem's in the individual, so it's an individual-focused thing, whereas open dialogue takes into account the social network. I've talked about these qualities and how they contrast standard treatment, where the expert holds the knowledge authority, the epistemic authority. Psychoeducation, the expert's teaching this person about this condition they have. And that there's a pre-existing menu of services that are tied to the particular diagnosis you've given them. That's the standard care. And in open dialogue, we like hub and spoke model, and now we like node hub spokes, is that this is also a kind of hub and spoke, and that the network meeting is the hub. And you can bring in anything. You can bring in drugs. You can bring in cognitive behavioral therapy. You can bring in, all kinds of therapy into it. But the hub of the treatment are these open, humble conversations with people. The person has agency and voice. And in open dialogue, where in standard treatment, the person is the object of therapeutic concern. And I've made this point multiple times today about what I think is important about agency. And I really worry that the narrative that we have now is an anti-agency model. Not for everybody, but it has that potential. And there's so many treatments out there, standard treatments, non-standard treatments, that require a person to be able to lean in, and it's hard to do that. And again, you don't want to shame someone for not eating better. This is a hard thing, but you want to at least rally a person's inner resources to work with you. And I think that the standard model can counter that, whereas open dialogue is a way, need adaptive treatment is a way of bringing people in. So the last part of my talk was going to be, what time is it? Yes, I'm going to stop soon. So the last part, and we can talk about it if there's questions, is how we're applying this. And the one thing I want to say is we've developed our own version of need adaptive treatment in Vermont with, I know I have people here today who have been a part of it. It's been an amazing thing. And we're trying to make it affordable, embedded in the public system. We're training people in our agencies. I think it's a really amazing, remarkable thing we're doing. And I'm really proud to be a part of this group, many of you are here, that are going to try to do something very innovative in this state. So I'm going to just go to my very last slide. It's really, what psychiatry got to do it, because I'm really talking about narrowing psychiatry down, and I'm really wondering whether maybe there are enough psychiatrists, but we have this distorted demand. And I think when we get involved, though, I think it takes some time. I think it's really complicated. And I think as psychiatrists, we need to actively give up the authority that society is given to. I'm looking straight, I'm not going to embarrass him. One of the judges here, he knows the kind of authority that's given to me. I can with my voice, have people put in hospitals and given medications against their will. That's a serious thing that weighs on me heavily and should. It should keep me up at night. And I think there needs to be a humility about what we don't know when we're going into these rooms and talking to not only judges, but to the people who are coming to us and to their network. And that's my final word, is to embrace humility and uncertainty.